Welcome back to the deep dive. We're taking fundamental knowledge, specifically from Kaplan and Sadock's comprehensive textbook of psychiatry, and really boiling it down for you. Today we're tackling, well, a pretty significant and serious area, pediatric mental health.
It's huge, definitely. And our focus today is zeroing in on those major anxiety-related disorders in kids and adolescents. We're aiming to systematically unpack the definitions, look at how common these actually are, some of the causes, and most importantly, the treatments that the evidence really supports.
Exactly. We want you to walk away with a really clear picture of what's going on clinically. We'll cover obsessive compulsive disorder, PTSD, that sort of common anxiety, cluster separation, social and generalized anxiety, and then selective mutism. Lot to get through, so let's jump straight into OCD in childhood, maybe the most complex biologically.
Yeah, let's start there. And defining it clearly is crucial because you have these two core components. First, the obsessions. These are thoughts, images, maybe impulses that keep coming back. They feel intrusive, unwanted, and they cause a lot of distress. Often they're ego dystonic, meaning the child feels like these thoughts aren't really them.
Right, like an alien thought popping in.
Okay.
And those distressing obsessions, they fuel the second part.
Precisely. The compulsions. These are the actions, the rituals, sometimes physical behaviors, sometimes mental acts that the child feels driven to perform. They're trying to reduce that anxiety from the obsession or maybe prevent something bad they fear will happen. It's the attempt to neutralize the internal feeling.
Okay, so classic example, fear of germs leads to excessive hand washing.
Exactly. Or maybe a vague worry something terrible will occur leads to constant checking or ordering things just so.
Right.
And here's a really key point for diagnosing younger kids. They don't actually need insight. They don't have to recognize their symptoms are excessive or irrational.
So that's different from adults.
Big difference. For an adult diagnosis, insight is usually considered. For kids, we don't require it.
Okay. How common is this? The source material hints it's maybe more widespread than people assume.
It really is. Lifetime prevalence estimates are around 1% to 3%. That's not insignificant. Onset is often bimodal, with a peak around 6 to 11 years old. And interestingly, before puberty, it seems to be more common in boys. And get this, up to 80% of adults with OCD say their symptoms actually started back in childhood.
Wow. So, okay, we've defined it. Let's talk causes. The textbook really frames this as neuropsychiatric, right? What's the main thinking there?
Yeah, it points strongly towards issues in specific brain circuits, the prefrontal basal ganglia connections. We often call them the frontal striatal thalamic cortical circuits, or FSTC.
FSTC.
Okay, right. The idea is there's some kind of disruption in how these brain areas talk to each other, affecting things like control and stopping unwanted thoughts or actions. Brain imaging studies have even shown things like reduced volume in specific areas, like the globus pallidus, and some kids who haven't had treatment yet. So for you listening, the point is, this isn't just a habit. There seem to be real, measurable brain differences involved.
And that biological angle leads us to something pretty surprising, sometimes controversial, pandas and PANS.
Right. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorders associated with Streptococcus. It describes this very sudden, almost overnight onset of OCD or neurological symptoms right after a strep infection, like strep throat.
Wow, like flipping a switch.
Exactly. The theory involves the immune system mistakenly attacking parts of the brain, like the basal ganglia, causing inflammation. PANS is a broader term for similar abrupt onsets linked to other infections or inflammatory triggers, not just strep.
That must be terrifying for parents. But the book clarifies something important about treatment, even in these cases.
Yes, absolutely. Even if you suspect PANDAS or PANS, the evidence-based first-line treatments are still the go-to. Cognitive behavioral therapy, especially a type called ERP, and SSRI medications. Those immune-focused treatments are still considered largely experimental. You stick with what works best for OCD generally.
Okay, let's touch on the psychological side, too. How does the book explain how these symptoms keep going once they start? Kind of bridging biology and behavior.
Well, that's where theories like Hobart-Mower's two-factor conditioning model come in. Basically, classical conditioning might create the initial fear link, like associating a doorknob with germs, but operant conditioning keeps the compulsion going.
Operant conditioning? How?
Through negative reinforcement. When the child does the compulsion, washes their hands, checks the lock, the anxiety goes down temporarily. That relief reinforces the behavior, making them more likely to do it again next time the anxiety hits. It becomes a cycle.
Which explains why the main therapy, exposure and response prevention, or ERP, is so crucial. How does that actually work? It sounds intense.
It is intense, but very effective. It starts with education, understanding the OCD cycle. Then you build a fear hierarchy. listing feared situations from least to most scary. Then you systematically expose the child to those feared situations, starting lower down the list. But the critical part is response prevention. The therapist helps the child resist doing the compulsion.
So, face the fear without doing the ritual.
Exactly. They learn the feared outcome usually doesn't happen, and crucially, that the anxiety does eventually decrease on its own, even without the ritual. It breaks that negative reinforcement loop.
Makes sense. And on the medication front, which SSRIs are typically the first choice?
So the standard ones. Fluoxetine, sertraline, fluvoxamine, paroxetine, those are first line. Clomipramine, which is an older tricyclic antidepressant, is also very effective, maybe even slightly more so in some studies, but it has more side effects and needs more monitoring. So it's usually reserved for second or third line if SSRIs don't work well enough.
Okay, that's a really thorough look at OCD. Now, let's shift gears to something rooted more in external events. Post-traumatic stress disorder, PTSD, in kids and teens.
Right. So PTSD always starts with exposure to a trauma criterion A.
Yeah.
We're talking actual or threatened death, serious injury, or a threat to physical safety. After that, the symptoms fall into four main clusters in the DSM-5.
Okay, what are those clusters?
You've got intrusion symptoms like recurrent memories, nightmares, then avoidance, trying to stay away from reminders, then negative alterations in cognition and mood, things like blaming oneself, feeling detached, loss of interest, and finally, marked alterations in arousal and reactivity, being hypervigilant, jumpy, having trouble sleeping.
And the book mentions some specific ways this looks different in very young children.
Yes, the criteria are adapted for kids 6 and under. For example, intrusion might show up as repetitive play where they act out themes of the trauma, or they might have scary dreams, but the content isn't clearly related to the event. It's not always a verbal replay. It could be more symbolic or behavioral.
That's important for parents and teachers to recognize. Now, in terms of what increases the risk, does the type of trauma matter?
It really does seem to. While a single event like a natural disaster can certainly cause PTSD, the research suggests that chronic or repeated trauma, like ongoing abuse or neglect, carries an even higher risk for developing persistent PTSD. And another concerning finding is that the longer the PTSD symptoms last, the worse the potential long-term impact, even showing correlations with things like decreased brain volume or lower IQ scores later on. It highlights why early treatment is so critical.
Which brings us to treatment. The book notes something interesting about medications for kids with PTSD specifically.
Yeah, unlike in adults where SSRIs have a clearer role, the evidence for medication effectiveness specifically for pediatric PTSD is weaker. Many trials haven't shown a strong benefit over placebo. So while meds might be used for co-occurring issues like depression or severe anxiety, they aren't typically the first-line treatment for the core PTSD symptoms themselves in children.
So what is the gold standard?
Trauma-focused CBT, or TF-CBT. It has the strongest evidence by far, and it's quite structured, often following the components laid out in the PRACTICE acronym.
Practice. Okay, let's walk through that. P is for psychoeducation and also parental involvement.
Relaxation skills.
Yeah.
Teaching kids ways to calm their bodies down. A is for effective modulation learning to handle intense emotions. The first C is cognitive coping. That's about challenging those unhelpful thoughts, like self-blame about the trauma.
Okay, then T.
T is the core. Trauma narration and processing. The child gradually tells the story of the trauma in a safe way, helping them make sense of it and integrate the memories. I, in vivo mastery of trauma reminders. That's like gradual exposure to safe reminders they've been avoiding.
Facing the triggers.
Exactly. The second C is conjoint parent-child sessions, working on communication support. And finally, E is enhancing safety, making plans for future safety, and building resilience. It's a really comprehensive approach.
It sounds like it covers all the bases. All right, moving from trauma, let's tackle that cluster you mentioned earlier, the anxiety triad. Separation anxiety, social anxiety, and generalized anxiety. Why group these together?
Well, they often overlap in symptoms, they frequently occur together, and thankfully the treatment approaches have a lot in common too. Let's start with separation anxiety disorder, or SAD.
Okay, SAD. This isn't just normal kid clinginess, right?
No, definitely not. It's excessive, developmentally inappropriate fear about something catastrophic happening during separation from primary attachment figures, parents, usually. It has to last at least 4 weeks in kids and really interfere with their life, like refusing to go to school or sleep alone. You often see physical symptoms, too, like stomach aches or headaches, especially before a separation. And nightmares often have separation themes.
And when we look at the causes across these three anxiety disorders, what's striking about the genetics of SAD?
This is really interesting. SAD appears to have the highest genetic loading of the three. Heritability estimates are potentially up to 73%. That suggests a strong biological predisposition for many kids with SAD, maybe more so than for the other common anxiety types.
Wow, 73%. Okay, next in the triad, social anxiety disorder, also sometimes called social phobia.
Right. This one is about an intense fear of being embarrassed, judged, or humiliated in social situations or when performing in front of others. In kids, a key point is that the anxiety has to occur in situations with peers, not just with adults. Etiologically, a major risk factor is something called behavioral inhibition.
Behavioral inhibition.
Yeah, it's a temperament style seen in some infants and toddlers where they're naturally very cautious, shy, and quick to withdraw from anything new or unfamiliar. It's a strong predictor of developing social anxiety later in childhood.
Okay, that makes sense. And the third one, generalized anxiety disorder, GAD. This is the worrywart disorder.
Pretty much. It's characterized by excessive, uncontrollable worry about a whole range of things, everyday stuff, future events, school, health, what friends think. The worries are often about realistic concerns, but the amount and intensity of the worry is way out of proportion. And diagnostically, there's a difference from adults here, too. Kids only need one associated physical or cognitive symptom, like restlessness, fatigue, or trouble concentrating, whereas adults need three.
And how does GAD stack up genetically compared to separation anxiety?
It's kind of the opposite. GED seem to have a lower heritability estimate, maybe around 30%. This suggests that environmental factors, things like parenting, learned coping styles, life stressors, likely play a relatively larger role in GED compared to SA.
So with all this overlap and these different contributing factors, how do we best treat this anxiety triad? What did the big CAMS study find?
Ah, yes. The CAMS study, the Child-Adolescent Anxiety Modal Study, was a landmark trial. They compared four groups: CBT alone, sertraline, and SSRI alone, combination therapy, CBT plus sertraline, and a placebo. The results were pretty clear. Combination therapy had the highest response rate. Around 81% of kids got much better.
81%. Wow. Better than either treatment alone.
Significantly better. CBT alone was about 60% effective, sertraline alone was about 55% effective, and both were better than placebo, which was around 24%. But the combo really stood out.
So what's the practical takeaway for treatment planning?
Well, it suggests a kind of stepped approach based on severity. For kids with a mild or moderate anxiety, starting with CBT alone is a really strong option. It works well for many. But for kids with more severe impairing anxiety, the evidence suggests starting with combined treatment CBT plus an SSRI like sertraline gives them the best shot at getting better quickly.
That makes a lot of sense. Okay, our final disorder today, selective mutism or SM. This one's had a bit of a shift in how it's understood.
It really has. SM is defined by a consistent failure to speak in specific social situations where speaking is expected, typically school, even though the child speaks normally in other settings, usually at home. Importantly, it has to last for more than a month, not just the first month of adjusting to school, and it can't be because they don't know the language or have a communication disorder like stuttering.
And the name change from elective mutism was important.
Hugely important. Elective implied the child was choosing not to speak, being defiant. We now understand that's not it at all. It's now classified firmly as an anxiety disorder in DSM-5. Most experts view it as a developmental variant or precursor to social anxiety disorder. The core issue is intense anxiety, specifically related to the act of speaking in certain situations.
So if it's fundamentally an anxiety disorder, what does the evidence say about treatment?
The strongest support, overwhelmingly, is for behavioral techniques. These are really key. We're talking about things like shaping, reinforcing successive approximations of speech, like starting with whispering, stimulus fading, gradually introducing more people or settings where speech is difficult, and lots of positive reinforcement. It's often done using a very structured hierarchy, and because it's so setting-specific, getting parents and teachers on board and trained in these techniques is absolutely essential. They need to be consistent with rewards and avoid inadvertently enabling the mutism by speaking for the child.
What about medication?
SSRIs, like fluoxetine, have shown some efficacy, particularly for more severe cases or when there's significant comorbid social anxiety. But behavioral therapy is definitely considered the first-line, foundational treatment.
Wow. Okay, we have covered a ton of ground here, from the brain circuits in OCD through the practice steps for PTSD, the genetics of SAD, the CAMS study findings. Having this kind of systematic structure really helps make sense of these complex conditions without feeling totally lost.
Absolutely. It connects the dots from the underlying mechanisms to what we actually do in clinical practice.
Mm-hmm.
And, if there's one big takeaway from all this, it has to be about the importance of early intervention. These aren't typically phases kids just grow out of. The literature is pretty clear that childhood anxiety disorders often become chronic or recurrent if left untreated. Getting in early with effective treatments like CBT and, when needed, SSRIs can really change that long-term path.
That's such a crucial point because these childhood issues don't just vanish, do they? The data shows they often morph into other problems later on, like the book notes links between early separation anxiety and developing panic disorder as an adult, or social anxiety potentially leading to substance use issues down the road. It really hammers home why addressing these symptoms early is so vital.
It really does. And maybe that leaves us with a final thought for you, the listener, to consider. Given that these early anxiety patterns can evolve, how could we potentially get better at screening or identifying those subtle early signs before the problems become so entrenched and start impacting adult life?
Hmm, definitely something to think about. Well, thank you for joining us on this incredibly important deep dive into pediatric mental health. We hope this breakdown was helpful.
Thanks for listening.
We'll see you next time on the deep dive.